everyone, I'm Lauren McCoy,
And I'm Christian Johnson.
and under the tutelage of Dr. Allison Kriegel, we are presenting a systematic literature review on pediatric preventive dental care in underserved areas. We are here to discuss the silent epidemic dental caries. Despite being as preventable as it is surprisingly the most prevalent chronic disease among underserved children. And when we talk about the gap in care, we are defining a specific group of vulnerable populations, which are those facing geographic isolation in rural areas, low socioeconomic status, and the challenges of marginalized ethnic identities. The core of the problem is that our traditional clinical models are failing. They place the burden on the family to overcome massive logistical and economic barriers when that just isn't realistic. Our objective is to move past these failing models and bring the care directly to the community.
The methodology we use to synthesize 15 years of literature from 2010 to 2025 was through a streamlined PRISMA protocol. We studied pediatric populations and structural interventions in educational programs. Through these sources, we reported outcomes of prevalent and preventative behaviors within equitable pediatric care.
Essentially, if we want to fix this, we have to stop waiting for families to come to us and start going to where the children actually are. Take school-based SeDR programs, for example. They are foundational for kids who don't have a regular dentist. These programs can cut cavity formation and permanent molars by up to 50%, and they are incredibly cost-effective and realistic to run. Then we have mobile dental clinics, which are essential for dental deserts and people in rural areas. They help bridge the gap in places where there aren't enough Medicaid providers and makes it much easier for families to get the care that they need.
Through our research, we've learned a hard truth. Access is not guaranteed utilization. Simply providing a dentist or a mobile van isn't enough to stop early childhood cavities. We are up against two massive barriers. First, health literacy. Many caregivers see dental care as a reactive emergency rather than a preventative necessity. Second is the logistics. Even if they have Medicaid, a free appointment isn't free if a parent can't get the necessary transportation or afford to miss work. If we want to save these smiles, we have to stop waiting for families to come to us and to come to them.
The key takeaway here is that long-term success requires moving away from one-time clinical camps and towards systems that are actually integrated fully into the community. In order to make that happen, we need culturally tailored education that respects a community's language and specific hygiene norms. The most successful models used an integrated approach, which combines things like fluoride treatments with structured education as well. We also have to ensure there are clear referral pathways so families know exactly how to get follow-up care. And finally, by teaching the mouth-body link, we can help caregivers see how oral health affects the whole body, which is one of the most effective ways to encourage real lasting changes in behavior and have them understand that it is something to be taken serious.
This is a little flow chart we made to help kind of explain our goals. At first, we want to start short-term clinical camps, for the people who need immediate needs, and to really help volunteerism for people that want to help, like us who are trying to get started with Healthy Smiles. After that, we want to make transitional programs and have a link with primary care and to teach people of health education as well as to get staff training. After that, we hope to join the local workforce and be integrated with the community so we can give sustainable and lasting preventative care.
To bring all this together, we can look at the Healthy Smiles and Healthy Hearts Preventative Program as a practical application of our research. This initiative was designed specifically by applying the evidence-based outcomes of this systematic review. This program focuses on bridging the health literacy gap by teaching the mouth-to-heart connection, which will help families understand how oral health actually doesn't just affect their mouth, but also their overall systemic well-being. And that is something to be taken seriously. Our final takeaway is that achieving true health equity isn't just about clinical procedures. It requires integrated models that address the constant interplay between a child's medical needs and the social determinants of health that shape their daily lives.
Where do we go from here? Now, our future direction is to prioritize skill-based and mobile interventions that focus on caregiver engagement to sustain behavior outside of the dental care chair.
These are the references we used. Before we conclude, we want to take a moment to express our sincere gratitude to our mentor, Dr. Allison Kriegel. Stepping into a systematic review of this scale was a major undertaking for us, and it's not something we're used to. But Dr. Kriegel's guidance was very important in helping us navigate the process. Beyond just the technical side of the research, she really challenged us to look past the clinical numbers and understand the human side of these barriers to care, really looking into the human mind. Her expertise and the clinical perspective she brought from the Medical College of Georgia really elevated this project and shaped how we view our roles as future healthcare professionals. We are incredibly grateful for the time, patience, and professional insight she invested into our growth. Thank you, Dr. Kriegel. And thank you so much for listening and taking the time to engage with this critical issue in pediatric health. We appreciate your attention to these findings and the impact they have on our communities. Thank you.
Thank you.